So hello, welcome everyone to this 9th Young IFSO Journal Club. We will have today two great sessions. The first one will be with Nicola Di Lorenzo from the University of Rome, and he is also the president-elect of IFSO EC, and he will have a keynote lecture with his huge experience about weight regain, the main present and future challenge for bariatric surgeons. And after that, we will have a second session, a paper discussion by Dr. Julian Süstrunk. He's from the University Hospital in Basel, and he will tell us about the incidence and prognostic factors for the development of symptomatic and asymptomatic marginal ulcers after Roux-en-Y gastric bypass procedures. If you would like to communicate with us, just write your questions, and we will then, after the sessions, discuss them. And before we start with Nicola Di Lorenzo, Wei Yang from China, he's my co-chair today. He will tell us a few words about the structure and about Young IFSO. Please, yeah.
Okay, thank you, Morris. Good day, everyone. Welcome again to our Young IFSO Journal Club meeting. This is Wei Yang from China, and I'm happy to co-chair this meeting with Morris, and I would like to show my thanks to Morris for organizing this on behalf of the European chapter this time. And also thanks to IFSO, the Secretariat, Manuela and Stephanie for supporting us. And of course, as well as the support from our President, Ian, who will join us a little bit later, and our past presidents, Sylvia, Kevin, and Alexander, and for their support to our group. And for the audience, if you are the first time to be here to join the Journal Club, please allow me to give you a brief introduction about IFSO and Young IFSO Journal Club meeting. So as you know, IFSO is a global organization composed of many 72 official member society all over the world. And it is a scientific organization that brings together the surgeons and also the integrated health professionals such as nurses, practitioners, dietitians, and psychologists, etc., who are involved in the treatment of patients with obesity. So for the Young IFSO Journal Club meeting, we will organize every 2 months, and on the first Friday evening. And so if you are interested, please pay attention to our IFSO emails for the members. So without further ado, I'm going to hand it over to today's chair and moderator, Morris, again. So Morris, please, it's all yours.
Okay, and before we start with the first presentation of Professor Nicola Di Lorenzo, you have a poll question, and it's about the definition of weight regain, and we will vote before and after his presentation, and we will see if there's something have changed then. Okay, 5 more seconds. Thank you. I think we can see the result of the poll question. Okay, we have 15% respect to the lower postoperative weight, the nadir weight. Professor Di Lorenzo, do you want to comment on this?
I'd like to discuss it after my presentation. I think it's more appropriate.
Thank you. Perfect. So I think we can start now with your presentation, and we'll then have the poll question again and the discussion.
Good morning, everybody. Thank you so much to the Young IFSO for this invitation. my topic is on weight regain, and the question mark is wrong, because for sure it's a future challenge for bariatric surgeons. You know that bariatric surgery since 1992, in the last 30 years, has grown up 70 folds or maybe 100 folds, becoming a daily practice all over the world. After 30 years, in this, let's say, roaring 20s, we have some hot topics. One is provocative, the first one to me. Second, third, reflux and luminal, combined therapies, many others. But when you talk about redo, weight regain is a big problem at the moment and for the future. We know how to evaluate the weight loss after primary procedure. The Reynolds criteria are still here, the total weight loss and other criteria has been established and approved by the societies. But when we deal with the weight regain, we are sort of Babel Tower, well represented by artists, but it's a big problem for us. The topic is very interesting. You can see that these 1,300 results on PubMed for weight regain, especially in the last years. So this means that the topic is gaining more and more importance. When we go to define the weight regain, it's different. We have these 42 results, and the interest is declining in the last years because of the difficulty to produce a good definition. And we will see how things went in the last 12 years. 2010, percent of weight regain over 15% from the nadir. Not a bad point. But then, from this paper from Melanie Lauti, you see that several authors from 2010 to 2016 has defined in different way the weight regain. And even in the IBC social media polls by Marius Nedelko and others, it's evident that not all the experts have the same opinion. This nice paper, systematic review by Wendy King, looked very promising, but look at the many authors, how much they have different opinion from the line of 100, which is the central one, which represents the reference. And at the end, the paper has been able to show the pitfalls in frequency and time of measurement, recommending to be more precise, to define the nadir, and to have a more accurate sample selection, but nothing more. Then the Power Task Force or SMBS looked very promising as well. You know how many papers they have screened, how many authors they have read, but at the end they were able to discuss much on the difference of if it's better total weight loss, it's better excess weight loss, percentage of course, but this is not the core point. They've had a final statement which is very generic. The only thing which I wish to stress, which is in my opinion very important, is that they also say that we should correlate with patient comorbid disease relapse. But now our patients are asking for our help, and they are facing a problem. This is an old paper, but for bypass, but it's the same for other procedures as well. So reduced surgery has become more and more important for many different reasons, but mainly for weight regain. It's an old story. Michel Gagné published together with a good friend of mine in 2002 this first paper on the reparative laparoscopic surgery. And I give you a short information from my data. I studied as many with a band in 22 years ago, and then I moved 3 years to more challenging patients as the one that you see here. But apart from simple operation, if I look at my record, I see that reoperation in yellow every 3 years are regaining more and more space, and now it's even more. All over the world, procedures have increased much in Europe and in the US as well. And so the percentage of redo for years has been a constant for about 6% and increased much in a few years, probably because the band has been introduced widely after the FDA approval without a correct way to follow up patients, but this is my opinion. It's more complex than this. So they decided to have a first international consensus conference on revisional in 2015 with many topics, but at the end of the discussion, very little consensus was obtained. There was no chance to draw and fund a randomized trial, And the only way they find to say that we can have an improvement was through a creation of registry, which has not been created, by the way. Then a consensus statement on revisional using a Delphi system in 2019. At the end, all these experts that you see listed here, very well known, they said that it's not possible, they agreed on the fact that it's not possible to lay down specific criteria for reduced surgery in terms of weight regain after primary surgery. Very, very difficult. The SMBS, if there is a problem of relapse and the disease is still present, additional therapy is required, including surgical options in case of weight recidivism. But because we have to prevent and study very well our patients, we have to understand it's a multifactorial aspect, which is not only surgery related, but also patient related, as you see here. So we skip the surgery related, we go for the patient related aspects. Many of these changes are in front of our patients when they do a primary. Eating behavior, food composition, nutritional supplementation, psychological issues, physical activity, and more. Let's start from biology or by behavior. On the right, for sure, it's behavior, but on the left, this Etruscan tomb from 400 years before Christ is probably biology. And there are some aspects related to nutritional points, which are in general important. You see the multi-hormonal control of body weight. It's the role of different signals. Should we blame our brain for weight regain in terms of adaptation of the central regulation and the intake? Let's see. And what about genetics? I will be very brief on these things, but think about that these two individuals are identical in 99.9. So the environment and other aspects influence very much our phenotype. And one point, for example, is the diet. In the last 100 years, it has changed so much. Maybe not 2 or 3 generations, maybe 4 or 5, but for sure our genes cannot change in such a quick way. So genetic factors, as demonstrated in this paper, strongly influence the effect of Roux-en-Y and other procedures on body weight. And we know from this paper that we published some time ago that adiposity, rather than BMI, determines the metabolic risk and the weight regain. And there are other aspects. I'm not an expert in this, but just to mention, polymorphism. Epigenetics, which means gene expression rather than looking at the genetic apparatus, and a topic which could take days, which is the microbiota changes and influence. Much more, we have others, psychological, psychiatric, behavioral. Very few studies investigated directly the factors that determine the weight regain, but for sure these mental disorders are things of alarm for those patients who are affected by these problems. And the correlation of psychiatric disorders to the bad results is very well demonstrated, as well as the correlation of anxiety and depression and alexithymia, that indicates the inability to identify and describe emotions. All these patients are at risk for weight regain or for inadequate weight loss. And more the physical activity. If you deal with this kind of people, be sure that they will not have a good result or will have a weight regain. Because it's been demonstrated that behavioral management is very important. We can do it traditionally, we can do it through the Internet of Things, keeping the patient monitored through the many devices that we have now. It's just a suggestion. But we also have to look at ourselves. And the lack of follow-up, the lack of study, it can affect very much our result and produce a weight regain. This is a dramatic result of a paper which I had the chance to review. It's about 22,000 patients in the pre or post-operative period. Have a look at nutritional therapy. Before surgery, 20%, after surgery, 9%. Psychology, 50% before, 8% after. This is a predictable way to have a failure. in both in the psychological aspect, in terms of nutritional support and advice. And finally, in this long run, I would stress also that you have to consider the comorbidities relapse, which is not only weight is important, and the impact on quality of life if this changes much in the so many informations. Many of them are true, of course, in different ways, looking at different perspectives, but I don't have the truth, and the truth is different from the single steps that we have discussed. So now we have to deal with the surgery-related points. We are surgeons at the end. And so here it's listed the kind of surgery-related aspect of weight recidivism, but I hope that after this first part of my talk, you understood what is my point of view. Reoperative bariatric surgery is important, but it's never surgery first. We have to work before to explore all other options. These are some to be used before the surgical approach and join to the surgical approach, having a combined attitude. And a typical one will be this one, which is a hot topic. Liraglutide and now semaglutide have a very good result on patients, not changing the situation of big patients, of super obese patients, but working on a category which is as a lower weight. It's not a competition. It's an additional tool that can help us preoperatively to boost our surgical procedure, and very important for the endoscopic procedures, and to help us for the weight regain. But now, again, as surgeons, we have to manage a surgical problem. And although we don't have direct evidence, randomized studies to indicate which patients will benefit from revision, we can draw the general effective concept, very general, without the presumption to be right in all the words I will tell you. And some patients, which are very well selected, have satisfactory additional weight loss after a secondary procedure. I will suggest you to read this very interesting paper by Kelvin Iga some years ago, but it's very well written on the revisional surgery concerning conversion, corrective, reversal. But what is the core point is that patients to be considered for revision must be optimized nutritionally and assessed very well, and should be operated by expert surgeons because it's a higher risk operation, and a center who has multidisciplinary resources available. This is also true coming from the guidelines that we developed also with Maurice Spencer, who was one of the pillars of those who work on this project. And concerning revisional, it is said that weight regain after bariatric surgery should be faced with this is the position statement, because there is no evidence-based criteria for indication to revisional bariatric surgery, but it should be faced with a complete multidisciplinary assessment as for a primary procedure. The fantasy of surgeons, of bariatric surgeons, is infinite, it's enormous, but we have to stay close to the main procedures. And in the procedures which I show you, you see also the BPD. BPD is not used anymore, but it's a big lesson that we got from the man you will see. And one of the lessons which remain to us, it's what I call the Scopinaros concept. Unless technical mistakes are evident, never add a failure to a failure. It means don't do, if you have a failure with a band, don't reposition, don't insist on that procedures because you think that you are better than the one who operated the patient before. And so for a band, don't go ahead with the same procedure. Go for a sleeve or a bypass with the same, more or less the same metabolic effect. After a sleeve, we have many options. You can have a re-sleeve in case that it's evident that some part of the stomach has remained, it's not dilated, it's remained. Or you can band, it's a very fashionable procedure at the moment, you can band the sleeve. Or you can have a rule Y, or you can have a one anastomosis or a SADIS. Sleeve is the first step of many other operations. After a one anastomosis in general would be a one ORGB or SADIS, it's more challenging because you can act on mainly on limb length, which is a delicate aspect also correlated to malnutrition. Last but not least is the Roux-en-Y, because Roux-en-Y can be a problem. In case of an hyperinsulinic hypoglycemia, you have to go for a restoration, and then you can have a sleeve, SADIS, whatever. In case of weight regain, you can have a longer limbs, demonstrated to have a good metabolic effect, but not much on weight. Or again, fashionable, you can band with whatever you want the pouch to slow down the passage. Or, just to give you a recent hints, a paper published no more than 3 days ago by my good friend Maurizio De Luca, transforming the bypass with the SAGI in a sort of one anastomosis gastric bypass. This could work. It's been demonstrated in its very first report. It's not a suggestion for everybody, of course. After bypass, a big step can be obtained by endoluminal procedure because it's been demonstrated that the dilation of the stoma is a risk factor for weight regain. This is an elegant paper by the group of Phil Schauer, where in the where they found an abnormal upper endoscopy with either with a stomach enlargement or a pouch enlargement of both, they were able to demonstrate that what correlates more with weight regain is the normal pouch and the large stoma. It's a sort of discrepancy as the one that I had on this ferry in Greece. If I had to escape from the ferry through this door, can you imagine what can happen? There are different systems for endoscopic bypass revision. These are listed here, but of course the one we do more is endoluminal suturing, which can be effective for pouch trimming and anastomotic restriction, which is the more important. I don't want to make any comment on the different procedures. This is the two which are more diffused, and I show you very quickly also the BAR project, which is, I'm one of those who work at the project, which is a modified clip that at the end can reduce the size of anastomosis. The good effect, at least temporary, of this suturing technique has been demonstrated by papers in terms of weight loss after the procedure and in terms of slowing down the food passage in the pouch by these elegant papers by Christine Stier. So I gave you an overview of all things. I'm coming to the take-home messages. Just a joke. I will give you the 10 without the presumption to be Moses on the Mount Sinai, just to have a little bit of a joke after a boring presentation. Number one, define if your patient has a weight regain. Difficult to define, but find what you think appropriate as a definition. Second, more difficult, even more difficult, define why your patient has a weight regain. What is important is to study the patient as for a primary procedure, number 3. So we explore all options before the surgical approach. Again, surgery first is not a good choice. Because surgery first is not a good choice, we explore everything. We deal with this different aspect and we work with our colleagues which are expert in the single things that we are talking about. Eating, exercise, and so on. 7, keep in mind the scoping arrow concept. Don't add a failure to a failure. Number 8, people now is using more and more a single procedure. Does one size fits all in all cases? No, one size doesn't fit all. You have to find a way to give the proper procedure to the proper patient. Don't think, number 9, to be more intelligent than your other colleagues looking for fancy solution, as it happens frequently in bariatric surgery. You are not Superman. And finally, experience comes also through mistakes. If you are not making mistakes, you are not working well enough. But if you make a superficial non-thoughtful choice. Be careful of the consequences. Thank you so much for your attention.
Thank you very much, Nicola, and for this very interesting talk and also for the 10 conclusions. So I think before we start the discussion, we would like to show you a poll question again, and then we will see if maybe something has changed between before and after your presentation. We can maybe have 5 to 10 seconds. Okay, can we see the result? Okay, thank you. So even more now for 15%. Nicola, do you want to comment now on that?
Well, this is this was the original definition of 2010. After that, many came. I see that what's more and more important for surgeons is not to look for the eligibility criteria, because it's not necessary to have people over 35 or over 40 to think about a redo or any kind of treatment for weight regain. So I think this is rather appropriate in terms of looking what has changed in the patient, not only weight, but also attitude and behavior related to food. We know very well that sometimes we have a perfect operation, we see that nothing has changed, and the people have changed is eating attitude and regaining weight. So the key point is to look at a certain amount of weight regained after the nadir. But again, one thing is to measure after 1 year or 2 years. One thing is to measure that after 11 years. So we have to define better, not here, but we have to define better the timing for measurement.
Mm-hmm. Can I ask something from your talk? Maybe it's a little bit a provocant question, but you mentioned the Scopinaro concept, never add a failure to a failure. Do you think this is true for sleeve and re-sleeve?
Well, the underlying opinion was, of course, that we use 65% of sleeves in our numbers, at least in Europe. So I think this is an over expectation of a surgery. No single surgery it fits for 2/3 of our patients. So I think this is a good point. If you have a sleeve which has a certain kind of effect, it's better to add a malabsorption, whatever you think is better, but to combine the two options to have a better result.
Mm-hmm.
If I got well your question, because I had a slight stop in the connection.
Okay. So some of the panelists having a comment or a questions? Yeah, Alexander.
Hello, everybody. Thank you, Nicola. Very nice presentation. I have a questions and comment in one. As we know, there's so many study about weight regain and something, but after 5 years after bariatric procedure, I think the data, 25% of the patients, or 50% of the patients take more than 25% of the lower weight loss. And you told that we need to choose right procedure. But in this context, if we see the weight regain after all bariatric procedures, what mean choose the right procedure?
Good question. Thank you, Alexander. The point is the following. I was trying to stress that we have to choose not the right, because I don't have of course, the pretension to say right, but the best procedure for each one in the primary procedure. This is very important, and this is not happening at the moment. First, second, according to the things that I said, look for the better solution for the weight regain. But on the other hand, you are totally right, because we are dealing with a chronic relapsing disease that is a lifelong disease. So in a sense, weight regain seems a little bit physiologic for, especially if you operate on a young patient. After 20, 30 years, you can expect a high rate of weight regain. So the attitude should be the one to treat these persons with obesity, not say patient, persons with obesity, with a sort of continuous way of keeping them under control, under follow-up, and adding other procedures or other way of helping them to stay at the right weight or closer to the right weight. It's again, it's a relapsing disease. It's not related to the stomach or to the bowel, so we cannot pretend to solve 100% of problems by surgery.
Okay, thank you, great. But I continue these questions because
yes.
In our polling, we've seen that 15% of the weight regain, it's a weight regain. But I think that maybe it's not too much, because 15% from the lower weight loss, it's not too big, because we understand that the lower weight, it's only a point in time when the patient, but maybe it's like a record for him. But for me, for example, I think that it's better, it's thinking that 25% of the weight from the lower weight loss, it's a better number. I don't know, it's like discussion, what you think?
Well, in a sense, the 15%, which is said by some authors, and the 25% that you say are closer, because after when the weight loss stops, we all know that there is a slight regain, which is the same for the diet and the same for all things. So probably, if you take as the nadir not the lowest, but the one after stabilization of the weight after the procedure, you will get in between the 15% and your 25%. This is what I guess, but again, it's a very personal opinion. It's not something which is written anywhere. It's impossible to find something objective in the literature. But I think that your proposal is very reasonable. Think about what I said. Try to consider not the lowest weight, which is also depending on the enthusiasm of the patient losing weight after the procedure, that they are happy for this and they struggle to go at the lowest one, and look at the weight after 6 months, one year. So maybe that's more reliable as the starting point for looking at the weight to gain.
Oksana, can you tell us about how it is in the UK? How is their definition of weight regain and how you're treating with that?
So in the UK, I think, unfortunately, because of our state funding, much of in terms of the treatment for weight regain at the moment is purely in the non-surgical sector. So more of the movement is towards the pharmacological treatments and the lifestyle management. But thank you, Nicola. In your talk, you mentioned about the importance of our long-term follow-up and having those systems in order to be able to detect these, because in our system, most places after 2 years, the follow-up in terms of the routine hospital-based care stops. So actually having a mechanism to detect weight regain isn't there and needs to be developed. But I wanted to ask you a question, Nicola, about your those 10 points were really, really interesting to me and very useful. And one of them that I found the most kind of the key one was the way you said about having multidisciplinary interventions, and that surgery first is never a good idea, and that we need to consider the endocrine factors, the biology and the genetics, as well as the lifestyle management. But firstly, how do we, together through our multidisciplinary teams, how do we bring all of that to then decide in the first instance what is the right approach for that patient? And the key thing I wanted to ask is, when do we then consider surgery? Because we know that with obesity and with it being chronic disease, the lifestyle management, the medical management is not often a long-term solution. People do fatigue with their effects of that. We know that lifestyle management doesn't work. That's why we do surgery. So when is the right time to then consider surgery for these patients?
Well, good question. Difficult answer, but I will try. Because we know that the right way to do things. This is what we know, that it's to study the patient again as for a primary. So this work with a group, and at the end, the same discussion that you have with the group deciding the primary procedure should be the one deciding the secondary treatment. But I would be much more cautious about going straight forward to the operating table, trying, and I think that we are now another big tool, which are pharma, try to see and to predict if the patient can lose weight again. But I think the most important thing is the psychological assessment, because the relapse can be frequently related to changes in the psychological attitude or so on. So maybe a preparation in this sense maybe can select better the patient which is good for surgery. But this is, again, an opinion. The key point is to go for the group decision. And I wish to just to say a single word. I don't want to take too much time, but a single word on a study which has been done with, on follow-up. Follow-up is lifelong, we know, conceptually for these patients. And there is a difference of result among those who come to the follow-up and see all the specialists the same day all together in the same morning, or those who go to the surgeon one day, to the psychologist the second day, to the dietitian the third day. The first group does better. This is almost impossible, I know, in most cases, but this is demonstrating that the alliance among the patient and the group is the key point to have the better results.
Yeah,
may I add some more comments on this? Many studies shows that in long term, the weight loss outcome or other outcomes is not much affected by the types of procedure. For example, Unrai gastric bypass or sleep gastrectomy, they show similar outcomes in long term, like 5 to 10 years after the surgery. And some study shows that what affect the patients more maybe their lifestyle after the surgery, and that also points out that Nicola just mentioned that the long-term follow-up is very important.
Question for me?
There's some other comments. Wei Shen, you want to comment on that? Wait, we cannot hear you.
I have one question, not only for Nicola, but for everyone. Recently, we met a lot of patients with unsatisfied weight control or weight regain, and they don't want to control their lifestyle. So will you regret to perform the primary bariatric surgery? And how long will you or your team to communicate these patients before the primary surgery to talk about the lifestyle control after the surgery?
This is a good question. I think this is part of the assessment in the preoperative part of the primary procedure. We have to be brave enough to say to some patients that they cannot be operated if they are not really convinced about following our advices. Not in terms, people think that they need a diet after the procedure. We all know that with a good procedure, you can eat everything, but in small quantity. So this is very important. If people is not convinced, you should keep them in the rolling process of helping them to understand better the procedure. Those who come to you say, doctor, I want to lose weight. I have something to do in 6 months. These people, you should not operate on. I know very well that it's difficult, but this is what we should do. Theoretically.
There's one last question from the participants, and I think after that we will go on with the next topic. So it's about surgical options after Roux-en-Y gastric bypass. They are a little bit limited, but there are more options after sleeve gastrectomy. And does this make your index operation? Does this influence the index operation you do as a first step?
To me, it doesn't make difference. I make the indication of the first procedure according to what the group consider to be the better one for the patients. My numbers are still made of 4 or 5 procedures. I don't have the 99% of sleeves like in the center who perform more than 1,500 procedures per year. So of course, it's more challenging, but think about the fact that the revision of a bypass can be tricky in surgery. Sometimes you redo all the procedure and you have the same effect, but sometimes you can have a very good result by endoscopic procedure. I would like to stress this aspect because slowing down the food can help much.
And there's one more question from the panelists. If we can have a comment on anti-obese medications for the indication of weight regain. Which medication would you choose best for weight regain after this? Maybe Roxana, I think this is something of your topic. Would you like to comment on that?
Maybe better. Certainly better. Certainly better.
Thank you for that difficult question. I think at the moment the GLP-1 receptor analogs have got the most evidence base, but we can't necessarily, it's all in terms of evidence. There are others in development with ghrelin antagonists or suppressants. So I think it depends on the evidence. And obviously there is one category that we have the most, getting the 5-year outcomes from now. But also, the key thing, going back to what Nicola was saying, that it's important to consider the biology of the patient. So we need to find out in terms of if these patients are responsive to those. So they may be not responsive to the GLP-1 analogs. They may be responsive to ghrelin, and by doing all of the working with our physicians to test their hormonal profile, first you would be able to then have a scientific approach to deciding which. So at this point, I don't think we can say, but we know we have to go with the evidence.
If I can add a single word, don't look at that as an alternative to surgery, but think of the several procedures as boosting the other. This, in my opinion, is the secret for the future procedures, including all the endoluminal procedures which are done now at the low BMIs that can have a better result with the help of pharma, let's say, of GLP-1 analog and so on, what Roxana said.
Okay. So I think we will go on to the second session. Julius from Basel will now tell us about marginal ulcers after Roux-en-Y gastric bypass procedures. So I think you can go on. You can start the video.
Well, good afternoon also from my side. Dear Chairman, thank you very much for the opportunity to present this work. And dear colleagues, I welcome you to today's IFSO Journal Club meeting. And I also thank Professor Di Lorenzo for his precedent keynote lecture, which was excellent. Thank you very much. My name is Julian Süstrunk. I speak to you from Switzerland, to be more exact, from Basel, and I present to you this work, Incidence and Prognostic Factors for the Development of Symptomatic and Asymptomatic Marginal Ulcers after Roux-en-Y gastric bypass procedures. This is a study we conducted in Limmatal Hospital Bariatric Center in Zurich in Switzerland. It was published last year in Obesity Surgery. I have no disclosures relevant to this work. Now let's dive right into the topic. Marginal ulcers are ulcers at the gastrojejunal anastomosis, meaning at the upper anastomosis in Roux-en-Y gastric bypass procedures. The incidence reaches from 0.6 to 16% in the literature, and several risk factors have been described, such as smoking, type 2 diabetes mellitus, the use of NSAIDs, corticosteroids, or a history of peptic ulcers, but also things like H. pylori infection or technical aspects such as a large gastric pouch. Nevertheless, the pathogenesis is not fully understood. It might be acid related because the mucosa of the jejunum that is anastomosed to the gastric pouch is obviously not used to the acid produced from the stomach. But there might also be some form of an ischemic condition leading to marginal ulcers, such as sutures at the anastomosis or staple techniques, or maybe even an ischemia which is relative due to tension because the root limb is anastomosed up in the abdomen at the gastric pouch. But there might also be an infectious pathogenesis, for example, in speaking of H. pylori infection. Marginal ulcers may present with common symptoms such as pain, anemia, hematemesis, nausea, or other, but they may also be asymptomatic and lead to perforation or acute bleeding without any warning. For example, in this case report, there's an image of contrast agent extraluminally due to a perforated marginal ulcer, and at the ventral aspect of the abdomen, we see free air as a sign of perforation. So in the most severe cases, it can also present like this without any warning. The objective of this study was to assess the incidence of marginal ulcers after Roux-en-Y gastric bypass procedures, and also to evaluate the according risk factors for marginal ulcer development. In this study, all patients undergoing Roux-en-Y gastric bypass between 2013 and 2018 at the Limmatal Hospital Bariatric Center were included. Preoperatively, all patients received an upper endoscopy. In case of H. pylori infection, an eradication was performed preoperatively without the confirmation of the eradication result. The operative procedure consisted of a laparoscopic Roux-en-Y gastric bypass. The gastric pouch was formed with 3 to 4 vertical staplers, meaning that in the end, there was a 40 to 50 cc gastric pouch. The roux limb was positioned anticolic, and the anastomosis was fashioned with a CEA 25mm circular stapler, and the mesenteric defects were closed. Most bypass procedures were proximal Roux-en-Y gastric bypass with the according limb lengths. Some of them received a very, very long limb Roux-en-Y gastric bypass, meaning that there was a BPL of 60 centimeters and a common channel of 1 meter, and the rest was an alimentary limb. And some patients received a long BPL Roux-en-Y gastric bypass. So it was as in this scheme, but the BPL was 150 centimeters. Postoperatively, all patients received the prophylactic therapy with PPI for 6 weeks, in this terms, pantoprazole. The follow-up was conducted after 6 weeks, 6 months, and yearly thereafter. And an upper endoscopy was performed in case of any suspicious symptoms, but also routinely after 2 and after 5 years postoperatively if the patients agreed to do so. Looking at the results, in total there were 568 gastric bypass procedures. The mean age was 40 years and the most patients were female. The predominant operation was a proximal Roux-en-Y gastric bypass with 86%. The median initial BMI was 41, and in almost 30% of the patient, a type 2 diabetes mellitus was present, and 43% of the patients had an arterial hypertension. H. pylori was confirmed in preoperative biopsy in 30% of the patients, and most of them received the preoperative eradication, only 2.5% a postoperative eradication. Reflux preoperatively was present in 42%. NSAID was taken by 7.6% of the patients, and 27% of the patients consumed alcohol 2 to 3 times per week. And only a small number of about 4% consumed alcohol daily. And almost 50% of the patients were current smokers. A current smoker was defined as more than 3 cigarettes per day that were consumed. Routine endoscopy, meaning without any symptoms, was performed in 256 patients, so 55% of the cohort at 2 years. And at 5 years, 65 patients could be motivated to perform a routine endoscopy, which is 38%. And of course, in case of any suspicious symptoms, also a routine endoscopy was performed. So marginal ulcer incidence is shown on this Kaplan-Meier plot. Here we see the time to ulcer incidence. And we see most of the ulcers occurred within the first 3 years. In the first year, there were 36 ulcers, and in the second and the third years, another 20 ulcers. And there is only very few that occurred afterwards. The median time to marginal ulcer development was 11 months. 77% of the ulcers were located at the jejunal site, and 21% directly at the anastomosis, and only 2% on the gastric side. 57% of the ulcers were biopsied. In none of them, H. pylori was detected. When we look in more detail at the outcome of the marginal ulcers, I show you this graph. In total, there were 86 marginal ulcers, which corresponds to a rate of 15.1%. A quarter of them were asymptomatic. So 21 patients had asymptomatic ulcers that were detected in routine endoscopy. All of them could be treated conservatively. Out of the symptomatic ones, 2 needed an urgent reoperation, 1 due to a perforation and 1 due to a gastrogastric fistula. Of the other ones that were treated conservatively, most of them received a follow-up endoscopy. 6 of them did not because they had either very small ulcers or they were lost to follow-up. Of the patients who received the follow-up endoscopy, 88% showed improvement or a complete remission, and 11% showed an ulcer persistence or even a progression, leading to 3 reoperations, and 6 could nevertheless be treated conservatively. Of the 88% of the patients who showed an improvement or complete remission after the initial ulcer, 13 of them showed a recurrence, ultimately leading to 5 reoperations. So in total, there were 10 reoperations. 2 were sutures of a perforated marginal ulcer. 2 of them had a resection of the gastrojejunal anastomosis and the new formation of the same anastomosis, and 6 of them had an anastomosis resection and received an esophageal jejunostomy. Looking at the risk factors in more detail, we performed a univariate analysis of potential risk factors. For example, in this graph, we see the risk factor alcohol consumption. The blue line shows daily alcohol consumption, and the green line shows alcohol consumption 2 to 3 times weekly. For alcohol consumption, there is a significantly higher incidence for marginal ulcer development as shown in this graph. The same accounts for type 2 diabetes mellitus, with a significantly higher prevalence of marginal ulcer in patients suffering from type 2 diabetes mellitus. And also smoking as a risk factor shows a significantly higher incidence in marginal ulcer. Other relevant factors which showed significantly higher incidences are a long BPL, Roux-en-Y gastric bypass, the use of anticoagulants, or the presence of an obstructive sleep apnea syndrome. But then to identify the independent risk factors for marginal ulcer development, we conducted a multivariate analysis. There we saw only 2 risk factors that are independent for the marginal ulcer development. One of them is an elevated HbA1c. This means for every value above 6.5% of HbA1c, the hazard ratio for a marginal ulcer development is 1.18. And in case of a current smoking status, the hazard ratio is 2.65, meaning that if you're a current smoker smoking more than 3 cigarettes per day, your hazard ratio of developing a marginal ulcer after Roux-en-Y gastric bypass is 2.6. All the other factors that were positive in the univariate analysis did not show to be positive in the multivariate analysis, meaning that they're not independent risk factors. So in total, we found an incidence of marginal ulcer development of 15.1%. This is relatively high compared to other literature. This might be due to the long and systematic follow-up and the high rate of routine endoscopies performed. And also in this cohort, there's a very high rate of smokers with almost 50%. Another factor might be the pouch size. There was a relatively large pouch, which means that there are more parietal cells in place that can produce more acids. So the acid-related component might play a role. Also, the duration of PPI prophylaxis was 6 weeks. Some centers give PPI postoperatively for 3 months or even 6 months or longer, which might also lead to less marginal ulcers. And there might be some point of the anastomotic technique to influence the marginal ulcer. In this cohort, these were all circular staple anastomosis. And for example, there was a work from Frank Vanderwald in 2011 where he compared hand-sewn linear staple and circular staple gastrojejunostomies in Roux-en-Y gastric bypass, where he could actually see that in circular staple anastomosis, he found the least marginal ulcer development. On the other hand, there's a cohort study from David Erdholm from the Scandinavian Obesity Registry, where they compare circular and linear staple gastrojejunostomy. And in this study, they did not found any difference in the incidence of marginal ulcer development. So the influence of the anastomotic technique remains unclear. The most marginal ulcers were diagnosed within 1 to 3 years after Roux-en-Y gastric bypass. Nevertheless, in the recent position statement of the IFSO on the role of esophageal gastroduodenoscopy after bariatric procedures, there is no clear recommendation if there should be a routine endoscopy after Roux-en-Y gastric bypass, and if so, at what time point. And also, there is no clear consensus on the duration and what kind of treatment of prophylaxis for marginal ulcer or treatment of marginal ulcer. So to conclude, marginal ulcer is a common complication after Roux-en-Y gastric bypass surgery, and a quarter of the patients are asymptomatic. Smoking and type 2 diabetes mellitus are independent risk factors for the development of marginal ulcers. We recommend a routine follow-up endoscopy 1 or 2 years postoperatively, especially in patients with independent risk factors such as smoking or type 2 diabetes mellitus. And especially in case of a confirmed marginal ulcer, treatment should be initiated, and there should definitely be a follow-up endoscopy to confirm the ulcer healing. So I thank you very much for your attention, and once again for the opportunity to present this work. And I would also take the opportunity to invite you for the next year's IFSO European chapter meeting, which will take place in Zurich in Switzerland. And I'm very much looking forward to meeting you there.
So thank you, Julian, for this great presentation. And of course, we will be in Zurich next year, and I hope we will also have a Young IFSO session there. So we have to organize that. So I have a question to your talk. So as we have seen that smoking is such a huge risk factor, do you think it should be recommended that only non-smokers will receive a bariatric operation?
Well, we've discussed this a lot internally. Well, obviously, it's already enough, all the behavioral changes that the patient has to undergo after a bariatric procedure. And in the same sense, to ask the patient to also stop smoking will probably be very hard. And then again, if you exclude these patients from a bariatric procedure, you're not making them any healthier, of course. So the idea to go behind this was much more to operate the patients anyway, but to have a very strict follow-up and also do follow-up endoscopy on a routine basis after 1 or 2 years, because we saw the highest incidence early after the procedures.
Okay, and I have another question. So you have shown that most cases can be treated conservatively. So this is also the experience we have. But on the other hand, you had some cases that need reoperations. And do you know the outcome of these reoperations? Because we, in our experience, have seen that a huge number of these patients that get a new anastomosis had also relapse of these ulcers a few years later. Do you have also experience on that?
Well, those that were sutured in case of an acute perforation, they also underwent follow-up endoscopy, and they often show ulcer recurrence or even the development of a fistula. And then 6 of these 10 reoperation included the formation of esophageal jejunostomy. And in these cases, we didn't see any recurrence of an ulcer, but what we saw were stenosis, which needed dilatation. And so it's a bit of a trade-off. I mean, if the pouch is long enough and you can make a new anastomosis, it might be a good idea. So you still have some reserve to still go to the esophagus. But then again, if you do esophageal jejunostomy, you have other complications that may occur. So it's not it's not very easy if you have to reoperate due to a marginal ulcer, because you often see further complications.
Okay. Are there any comments or questions?
Thank you, Julian. That was a brilliant study and brilliant presentation. Much of all the questions I had, you already answered in your discussion. But one of the things I found the most interesting, firstly, how high the prevalence is, especially for an operation that we usually consider an acid-reducing procedure. There's a lot of talk now in terms of around, especially in the UK, about using Roux-en-Y gastric bypass for people as an anti-reflux procedure for people with BMI over 35. But your findings that you suggested in terms of the site of all the ulcers and being mostly jejunal as well, do you think that perhaps we should be more cautious in using it as an acid-reducing procedure? Should patients be on PPI long-term then?
I mean, it's a bit of a different thing that we discussed about. I mean, the patient usually don't suffer from reflux after Roux-en-Y gastric bypass, but the marginal ulcer, as we saw in our study, often occurred on the jejunal side. So there was not really a reflux esophagitis. So it's actually not a problem at the esophagus, but then again at the roux limb. So I mean, in case of smoking or a badly controlled diabetes, I would definitely recommend to have a long-term PPI, even though you perform the Roux-en-Y gastric bypass procedure. But I mean, if there is no risk factors, it's still a very good operation in case of reflux and obesity. So.
Yeah, the number being, well, the 50% of patients being smokers as well. Were they still active smokers afterwards, or this was their preoperative?
I mean, this is one of the most frequent things we discuss with the patients when they show up with epigastric pain, with an ulcer, or after the Roux-en-Y gastric bypass. But it's so difficult, even if they come to the smoking cessation clinic and they try to adhere. I mean, the smoking cessation is a huge problem. Even though there is good behavioral therapy and varenicline therapy and everything, the relapse of smoking is very high, and we can't really force the patients. Even if you tell them, you know, you might even run into another reoperation with esophageal jejunostomy. We do our best, of course, but that's about as far as we can go.
Our experience is also if we want to do the treatment conservatively, so we do double PPI, but it won't be successful if they don't quit smoking. So this is the experience we have. So we have a question from the panelists. So if we suspect marginal ulcer, what is the best imaging technique? Is it a prior gastroscopy? Is it barium swallowing, or is it CT scan? So anyone want to comment on that? Or would you go immediately for gastroscopy?
In our case, we always go for the upper endoscopy to look at the ulcer. Is it bleeding? If it is bleeding, you can also react immediately and might inject adrenaline or clip it or whatever. If you have an acute pain and you want to exclude a perforation, and you might even have to perform at night a CT scan to exclude this. But the upper endoscopy has to be performed, and depending on how the patient presents, you might have to, in the acute setting, add also a CT scan. If you do a barium swallow, even if there might be a small perforation, it's even possible that you don't even see a leakage. So I don't know if there's a high, if it's very useful to do the barium swallow.
Okay. Alexander, do you have
I would never say barium if it's a suspected perforation. Take care, it's not barium, otherwise it could be a disaster.
Yeah.
In our practice, we normally try to refuse this kind of surgery for smokers, and we talk with patient, and because it's really a big problem. If patients smoke, you don't stop. And in your practice, Julian, tell me please, the patients, for example, if you find a marginal ulcer and you treat, you see that it's not good, the patients didn't stop or stop. They're afraid or not afraid, normally.
I think the patient kind of neglects the problem often, because I mean the pain is there, or there was 1 or 2 endoscopies, and they take the PPIs. They normally adhere very well to the PPI therapy, but I mean many smokers neglect all the risks. It's not just the risk of marginal ulcers, but the risk of whatever cardiovascular problem that they might develop. So I mean this vast capacity of neglecting this danger is very typical in smokers, and I mean they do this in the same sense in the marginal ulcers.
Okay, and it's just more. It's interesting to discuss about marginal ulcers and compare with MGB or AGB, for example, procedures and Roux-en-Y, because it's exists too, and the smokers it's always very heavy ulcers with MAGB.
I think this is interesting. So so we don't have data on that yet, but from my experience, I think the ulcer rate is a little bit higher in one anastomosis gastric bypass. Even I don't know if it's true or not. This is just the experience I'm currently feeling because I'm doing a lot of endoscopies in these patients. But does someone has data on that or has same experience?
I don't have yet.
Okay.
May I put a question? I'm not one of the discussants, but it's coming to me. If in those cases which are not in emergency, and you see that it's not improving much, do you consider the study of gastrin in these patients? Because our fathers, my fathers and your grandfathers, knew very well in the age of ulcer the concept of the retained antrum and the difficult duodenum. So this could be a thing to be studied, and we know very well that if you have the one anastomosis as a second procedure, you leave a part of the antrum which could be responsible for the high rate of ulcer that can be observed.
Okay, so we have 2 more questions from the panels. So how long would you treat with PPI? So maybe I can say the experience from our hospital. So if we do a primary bypass procedure, we are normally doing 3 months, 40 milligram of PPI, and in smokers we give them the PPIs for 1 year. And in case of ulcers, we are doing for 2 months double PPI, so in the morning and in the evening 40 milligram. Someone else want to comment on that?
I actually have a question for you. What kind of PPI do you give, and how do you give it? Do you dissolve it in a little bit of water, or do you give the entire capsule, for example, esomeprazole?
So we give them esomeprazole, the entire capsule, and in ulcer patients, so normally we give them Nexium. I think the intrinsic activity is a little bit higher, and 2 times a day. But
yeah, because there was an interesting study from Boston a couple of years ago where they showed that the ulcer healing is much faster when they gave the open PPI instead of the intact capsule, because they postulated it was reabsorbed much better after Roux-en-Y gastric bypass. And therefore, we're really launching a study to examine how is the absorption of the drug actually going after Roux-en-Y gastric bypass. So we're comparing as a pilot study 25 versus 25 patients, giving it intact capsules and open capsules, and then measuring the serum level of the pantoprazole, and also placing a wireless pH measurement in the pouch to see if there is really a reduced acid production or not. Because most surgeons, they just give the PPI as if there wasn't a Roux-en-Y gastric bypass, but we actually think that the reabsorption of the drugs is worse than we actually assume.
Okay.
So what you think about it, but I'm very curious of how you do it.
So I said as I do, someone else. I've never heard about that, to open it up, but
no, I think that's really interesting. I look forward to hearing the results of the study, because intrinsically, perhaps you would expect in terms of the speed of access or local availability. In many of the centres that I worked at in the UK, in our centres, we give the lansoprazole fast tabs for the immediate post-operative phase, and then inevitably, because they're on the liquid diet, so it's mostly to avoid further capsules. But perhaps that is then actually having benefit if it is the different route of availability, so it's sublingual dissolvable.
Mm.
there's another question from the panelists. So if there's a higher chance of marginal ulcers in converted patients from sleeve gastrectomy to bypass versus primary bypass procedures. So I don't have
probably Professor Dior answer on this. We didn't exactly study this, because these were all primary procedures.
as well primary. Mm-hmm. Okay. Any other questions?
I have a question.
Yeah.
I think it is more important to prevent than to treat marginal ulcers. In our center, case manager and I will contact every patient every 3 months in 1 year after surgery, and once every 6 months after 1 year on WeChat or QQ, to help them to avoid wrong living habits and tell them the importance of follow-up. If there is some complications, including ulcers, poor weight control and blood glucose control, severe reflux, we will talk to them more frequently. So how often will you contact your patients if they don't come to hospital to follow up?
Well, I mean, in our hospital, we see them after 6 weeks, 6 months, and then every year they come to the clinic, but we don't contact them on a telephone basis, because all the patients are followed up yearly, like lifelong. So it would be like a very very intense follow-up if you also have to call them every 3 or 6 months, and which also means a quite of a resource that you have to invest, and that you might not even get paid by the health insurance. So we see them yearly where they come to the consultation.
So, and as I understood your presentation right, so every 2 years you're doing endoscopy in smokers and diabetics after bypass?
After 2 years, we ask the patients to have an upper endoscopy. If they agree to do so, we do it, and then again after 5 years. And if in both we don't find anything special, no dilatation, no ulcers, nothing, we don't repeat it.
But it's a huge number of patients. So do you do it yourself in your hospital, or can they go anywhere they like?
Yeah, in Switzerland, it's not the surgeons doing the endoscopy, but it's the gastroenterology. Yeah.
Okay, so they do that. Okay, because sometimes for non-surgeons, it's not too easy to find the ulcers in asymptomatic patients, because normally it's a little bit below the anastomosis, so you have to invert the gastroscope a little bit, and often we have some patients that had the endoscopy somewhere else, and it was just normal, and then we have looked again and have seen a huge ulcer, and it wasn't seen in the endoscopy in the private sector.
Yeah, well, in the endoscopy in the hospital where we have a huge bariatric unit, of course, they're very trained in doing it after gastric bypass or other bariatric procedures. So they also do the stent placement in case of a leakage or anything. So they're very skilled in that. I assume well, I hope they find most of the ulcers.
Okay, so thank you very much. I think we will close the session and close the discussion now. There's one announcement from Nicola. So if someone wants to have his presentation, just write the IFSO secretaries, and you can download that. Thank you for that, for having this presentation. And then I have also an announcement for the next meeting. So I think Aaron is not here. He wanted to say a few words, but he has to go to the OR. But we have our next session at the IFSO meeting in Miami, and the Young IFSO session, Aaron Taksin have organized that, will be on Thursday, the 25th of August. It will be between 3:30 and 5:30, 2 hours session, and we will have great presentations there, and I hope I see as many as in person. And I think this will the first meeting where our Young IFSO group meet in person for I think 2 years. Thank you for being here. Have a nice day, and the next Journal Club will be after the summer. Goodbye.
Thank you.
Thank
Thank you.
Bye. Thank you.
Thank you.
Nice.